All right, thank you, everybody. So I am Holly Hoefgen. I am the co-chair of the Education Subcommittee for the Pediatric and Adolescent Committee. And so we're presenting our webinar today where we're going to go over ovarian tissue cryopreservation and sort of practice patterns and barriers that we're seeing in our pediatric centers across the United States. So I will also be presenting today. I'm a pediatric and adolescent gynecologist at Washington University, and I am the co-director and co-founder of our fertility preservation program here at St. Louis Children's Hospital. Co-presenters today are Chelsea Kebodeaux. She's a pediatric and adolescent gynecologist at Nationwide Children's Hospital in Columbus, Ohio. She is also part of the fertility and reproductive health program there and is a clinical assistant professor at the Ohio State University College of Medicine. We also have Megan Pruett with us, who is a pediatric nurse practitioner at Children's Healthcare of Atlanta. She provides fertility preservation counseling to hem-onc patients and cares for cancer survivors who have endocrine late effects. She also is the vice chair of the Patient Navigator Committee for the Oncofertility Consortium. And then also we have Amanda Saraf with us. She's a pediatric oncologist at Riley Hospital for Children at Indiana University, and she is the medical director of the Oncofertility program at that institution. So with that, we're just going to kind of get started. Background for today's, oops, sorry, wrong screen. All right, background for today's talk. In 2019, as I'm sure all of us are very well aware, ASRM published guidance that stated that ovarian tissue cryopreservation was no longer considered experimental. That next year, the leadership of what was then the Pediatric Initiative Network, which is now the Pediatric and Adolescent Committee, published an article discussing special considerations in pediatric and non-oncology patients, right? And the gist there was basically like, we are all very happy that this experimental guideline has been removed, and this is a step forward for fertility preservation, but also keeping in mind that in some of these special populations, such as in pediatric populations and non-oncology populations, we just need to be careful in the fact that we don't have as much data, and we need to think through those things, right? Now, ovarian tissue cryopreservation still remains the only option for our pre-pubertal patients. So it is a very important option in fertility preservation. But there is a lot, like very limited data on what the practice patterns are for offering and completing OTC in these pediatric, adolescent, young adult patients, right? So this, what we did was we surveyed all pediatric centers in the United States who are practicing and developing OTC programs. Well, everyone was invited to complete the survey. We disseminated it through the Oncofertility Consortium website and through emails and listservs, and also through the Pediatric and Adolescent Committee, with the goal of having just one survey per institution. So we could get really an idea of institutional practices as opposed to individual practices, right? So from this, we did have responses from 28 programs, which really represented a very large geographic outline of the United States. They were largely academic centers with 85 to 86% of our responses coming from academic centers. Of those 28 programs, 22 of them do currently actively perform OTC at their institution. We had two parts to this survey. So one was a survey on if you are actively have an OTC program, how is that run? What are your practices? A number of questions regarding that. We also had a secondary survey for programs who did not have a OTC program or who had a newly started an OTC program. So there were, I believe, 8 institutions that answered the barrier question, having one institution who answered both. Okay. Now we're moving on.
So to begin, we asked respondents to select all providers that participate in fertility preservation counseling at their institution. So the majority include fertility patient navigators, followed by gynecologists at 58%, treating oncologists at 33%, endocrinologists at 16%, and then other at 25%. There was no additional specific information about the other category that was provided by any of those institutions. And then to follow, we asked at each institution who provides the majority of the consultations. And so the top two, fertility navigators and other at 32%, followed by gynecology at 27% and endocrinology at 9%. Important to note that the treating oncologist was also an option here, but no one selected this. And again, there was no further information from institutions that selected other. Okay, so then we asked questions about risk assessment, in particular, what materials each institution used to provide risk assessments for patients. So the majority used the PIN risk stratification grid, followed by institutional minimum treatment thresholds. Some included Oncofertility Consortium materials, Livestrong materials, and other resources as well. We then asked, of those that offer OTC, which risk stratification do you offer for? So the majority of institutions offer for a high level of increased risk, but about 70% will also offer for patients who have a significantly increased risk. And then of the patients who receive OTC, we took a deeper look at the various patient populations that are served at each institution. So the majority of institutions offer OTC to oncology patients who are expected to receive gonadotoxic therapy. 87% offer to relapse oncology patients. 83% offer to non-oncology patients expected to receive gonadotoxic therapy. 71% include patients that will be at moderate risk. And then 29% will offer to patients with Turner syndrome, 20% to patients with differences of sexual development, and 16% for transgender or gender nonconforming patients. And then of the patients that are receiving OTC, we asked each institution when they are offering the procedure. So all institutions offer OTC prior to the beginning of therapy. 79% will offer either in between treatments or during treatment. Only 33% are offering OTC after treatment is completed. And about 70% of institutions are offering at relapse. Most programs, about 68%, will refer patients to outside facilities for OTC if OTC is not offered at their institution for certain patient populations. So for example, institutions may not include DSD in their protocols, but will refer to a program that has more experience in this.
So our next slide, surgery. Okay, I'm bringing you the. There you go, Chelsea. Sorry.
No worries. So as far as the surgical approach for ovarian tissue cryopreservation, institutions who filled out the survey most commonly reported pediatric gynecologists being involved in about 3 of 4 centers, closely followed by pediatric general surgeons, and very few reported involvement of adult gynecology surgeons as well. The most common surgical approach was laparoscopic, and within the survey, it was specified that 100% were approached it laparoscopically if there was no other indication for an open procedure. So open was only performed if the patient needed that for some other procedure. And then unilateral oophorectomy was also the most common procedure performed. followed by unilateral salpingo oophorectomy in 4.2, so taking both the full ovary and the tube. And then about 4% also reported making the decision on which tissue to take based on patient factors. And those included patient age, patient pubertal status, the proposed gonadotoxic risk, as well as patient preference as different patient-dependent factors that they use to decide what tissue to take. We also ask if unilateral partial oophorectomy was something that was performed, because both anecdotally and reported in case reports in the literature, portions of the ovary are removed instead of the entire oophorectomy. But interestingly, none of the survey respondents selected that as a procedure that is performed in a standard fashion. And then we also ask, as far as the surgical technique, what approach was taken, and about a third use electrothermal bipolar energy, 23% use ultrasonic, 9.5% use a cold technique, and then 33% of respondents were uncertain. As different types of providers could be filling out the survey, it's possible that some of the survey respondents were more familiar with other aspects of this rather than the surgical technique. Not sure how to do the advancement.
Are you able to move your screen? You should be able to remove it just with your mouse. If not, I can move it for you.
Sorry about that. Yeah, it says I can do it, but I don't know how. Okay, so the majority of the number of OTC cases per year was quite varied in the sample. So about equally, there were some institutions that performed just 0 to 5 per year, and then the equally common number was about 10 to 20, and only 14% of institutions performed more than 20 procedures per year. So even the high volume centers were, this isn't a particularly common procedure generally at the institutions that were surveyed. The majority of the time it was paired with another procedure, either every time or most of the time, more than 85% of respondents. Go to the next slide. So tissue is sent to pathology about 2/3 of the time in the institute, or at 2/3 of the institutions that were surveyed, with another third saying that they did not send tissue to pathology, and 4% saying that they sometimes sent tissue, and 75% of centers said they sent less than 5% of the ovarian tissue removed for the cryopreservation. And then it was quite mixed in which segments of the ovary that were sent, whether it was the whole ovary, the cortex and medulla, or the cortex alone. And when we ask what the majority were providing, there weren't really responses. So as far as tissue processing, most centers use the Origio Cooper surgical OFC media, and then 18% used another media and then didn't specify in their responses what that other media was, and no one used lactate ringers. And then the majority of centers reported using an outside compensated service, and when asked to specify, all those institutions said that they were using UPMC for processing, and then 42.9% used an REI group, and some of those were institutionally related, and some of those were an outside REI group that the institutions had contracted with. We also wanted to ask about research processes as far as OTC, and were institutions performing OTC as the standard of care or under an IRB protocol? And 63% were performing this as a standard of care. That was about 15% or 15 institutions of the 22 who were actively doing OTC. And then we only had 7 responses as to when they moved from IRB to standard of care. And there was one in 2021, one in 2022, two in 2020, and then 3 reported having never used an IRB. So presumably maybe started their program after the ACRM guidance. And of those who perform a standard of care approach, over half do utilize an IRB for data collection. And then almost a third do OTC under an IRB approved research protocol. And then 4% reported a mixed approach, depending on the patient. And very few are collecting tissue for research, or almost a third, with 27% saying that they do collect tissue, and an additional 9% saying that they make it optional to the patient to collect tissue for research.
And then, okay, Megan, you should have control now.
Okay. Oh, okay, good. All right, so these next questions pertain to sort of the money or financial pieces of OTC. So about 30% of sites that were surveyed are in states that have a law mandating insurance coverage for fertility preservation, but the coverage of OTC under that law was a little bit more variable. So of those that had a mandate, 14% reported that all of their OTCs were covered, and 57% covered some, or I think the question was worded some or most OTC cases. So even those with a mandate didn't have 100% coverage for OTC specifically. In terms of insurance payment outside of a mandate specifically, about half the centers reported that they were getting OTC covered most or all the time, sometimes about 22%, and then rarely or never 13%, and then we had a section of unknowns. When we asked about the typical cost of the OTC procedure, we divided it between OTCs that were bundled with another procedure versus like a standalone procedure. So you can see on the left side, these were the bundled procedures, and the reported cost for OTC was much lower, and those presumably because things like OR time and anesthesia and stuff were shared by the other procedure as well. And then when you get into the standalone procedures on the right, we saw a much higher percentage of OTCs falling into those higher cost categories. 62% of the surveyed sites reported that they had philanthropic funds that were available to offer to patients. Of those that have philanthropy at their disposal, 73% of those funds are internal, just within their institution, and then 20% additional said that it's a mix of internal and like external funding. So these are sort of the barrier pieces. Like Holly said, we had 8 respondents that reported they either do not have an OTC program currently, or they have one, but it's very new. So they were very familiar with their recent barriers and what it took to get their program up and running. So we asked about what their, most significant barriers were. And the 2 biggest things reported were lack of priority within their institution, like leadership didn't support this, kind of getting off the ground, and lack of protected time, as in human resources, like for either an existing fertility team or, to bring on new people in order to facilitate offering this procedure in their institution. So those were the top 2. And then sort of the next 2 down were lack of funding, and then also trouble with resources to process the ovaries. I think earlier we discussed centers that refer patients to other hospitals. I mean, we were talking then, I guess, more about for certain patient populations that may not have full coverage or offering OTC for every type of patient, but this is more pertaining to centers that didn't have OTC available at all. So the majority of these respondents, 5 out of 7, said that they do allow patients to travel or refer patients to travel, but that 85%, the patients are traveling between 50 and 200 miles. And then there was one center that reported that the patients have to travel over 200 miles to reach, the closest center that's offering OTC. So those were the most significant barriers reported.
All right. And then, our final points, we wanted this to be pretty interactive. So the goal was we kind of like half of the time we're going to present what we found from the survey, and then hopefully have some open discussion about what our thoughts are around the survey responses. I mean, are we surprised by them or not surprised with them? Where are areas that we are proud of ourselves and areas that we see room for growth and improvement, right? So just to kind of start the discussion with what are the things that we think that we are doing well. Our evaluation of the data, it does seem that with the grid from the Pediatric Initiative Network, that there is a much more standardized approach to risk assessment between institutions, which I think is a very big positive. Because I think that was difficult before we had like one resource that the majority of people were using. It could be very difficult to determine a risk assessment. You're pulling in information from lots of different sources, and people may have different sources or different opinions. So I think that is a positive that we're seeing here. And that, with us all, majority of people using a similar risk stratification tool that standardizes it across institutions. Also, it does appear like even though the numbers are still smaller, there is increased access to OTC for non-oncologic patients, as well as oncology patients that are in mid-treatment. I think those numbers are they're going to be smaller until we have more data, right? So we do acknowledge that these non-oncologic conditions, many of them do not have a lot of data for utilizing OTC and what that might look like in the future. And also acknowledging that for many of us, we live in states with restrictive laws that prevent us from offering cryopreservation to other patient populations, such as our transgender patients or sometimes even our DSD patients. You guys are free to unmute now. Does anyone else have thoughts on those two topics or on other things that you saw in the data that you feel is something that we're doing well at this point?
This is Karen Albritton. I'm at Cook Children's in Fort Worth. And I'm sorry to see that we didn't get a survey in. I think this was done right at the time we were losing our fertility navigator, so I apologize for that. But I love having the PIN assessment tool. It's great, and it's so nice to have a standardized roadmap. Obviously, it's something that's always going to be in flux. And I think the places that I'm really hitting up against the most like brain farts are in transplant, where the recommendation that it's, universally high risk, but there's so much variation now in the prep regimens, and especially for like a sickle cell patient or something like that, where I've found I'm really having to have more nuanced conversations with the family about whether it's what the risk is. And then obviously for newer drugs, drugs that we just don't have information on, targeted agents, et cetera. And so just, sort of how to, it's great to have a tool, but to sort of how to make it really a mobile or what am I trying to,
Right, something that's updating. Yeah, so I know Lillian's not on today, but I know she has mentioned in several of our meetings that they are working on revamping the tool, right? As there's new agents, and also possibly making a separate tool for oncology patients versus non-oncology patients. So I think that is very important that it needs to be more of a working tool, right? It was like we had nothing, so we created something. It is like 100% better than what we were using before, but we always know, right, that we're like working with continuing data. I also think, interestingly, with the bone marrow transplants, I usually talk through the study out of Cincinnati within the past year or two that showed that even though some of the lower risk bone marrow transplant regimens seem to be better for hormonal status, right, in the future, that they all still were very high risk as far as fertility, and kind of realizing that those can be two separate functions of the ovary. So from a fertility standpoint, at least at that time when we did the study, right, that they still were all high risk. So I routinely, I still call them all high risk and be interested in what other people are doing. But I do agree that, knowing that needs to be kind of a fluid assessment as we go forward. Chelsea, do you or any of the other speakers have anything to add on that?
I don't have anything to add on that specific question, but I think one thing that the survey illustrated we're doing well, which kind of surprised me, was despite the fact that the majority of respondents didn't have state insurance coverage, that we were doing a good job bundling the surgeries and keeping the costs overall down, because I'm sure we've all experienced that this is such a tough time for families, and then to have to bring up finances and the significant financial burden and feel like a patient can't get something based on cost is really difficult. And I experienced that when I was a fellow training in a different state. But I think that was another thing we were kind of curious about the state of that. And I think it showed the state was better than I expected, like the current status in terms of coverage.
Yeah, I think it also very much highlighted the importance of bundling, right? I mean, from a health perspective, we try to do that anyway to limit repeat anesthesia in these higher risk patients. But it is a very drastic difference on if we're bundling the procedures versus doing them alone. And I think at least a good amount of the participants who filled out the study also had at least some philanthropic funding for their program to help. So I think that is a good thing to see too. It's unfortunately those things don't always last forever, and some of us, they may be hard to get and maintain. But it did seem like a good amount of the respondents were able to provide at least some philanthropic funding. Any other thoughts as far as positives in the data from any other participants? Okay. And then the other things we had as far as now looking at like what are concerns that we see from the data or areas that we could like continue to improve on OTC. The two things that we had kind of noted as discussion points is one, that we see there is a really high reliance on the Oncofertility Consortium media or the Origio media. And we have had a lot of discussions within the consortium over the past couple of years about continued access to that media, right? So that kind of stuck out to me as something where we, need to be looking ahead to say, okay, everyone is using this, so what happens if we no longer have it? And I think there may be some of you on today who are working in that space, so I'd love to hear your thoughts on that. Any discussion on the media topic?
I was wondering if we have representatives from any other countries, because I know we surveyed the United States as sort of our first survey, but if there are anyone on the call from other countries, what media is used elsewhere?
That's great. Do we have anyone on the call from a non-US based program? we might have limited that participation with our title.
Yeah.
But yeah, I think that would be very good now, you know, with the expanding international participation in the Oncofertility Consortium to kind of look into that, right, with what everyone else is doing. And then the other area that we had marked as an area of a concern was that even though we are seeing, you know, more access to special populations, that the overall access for ovarian tissue cryopreservation remains a challenge, right? Both financially, because even though we're doing a better job, that is still limiting to a large population of patients. And I think also the barriers show that a large number of programs are not able to start because of a lot of those financial barriers. And then also geographically, right? So in our institution, we're the only institution in St. Louis who is providing ovarian tissue, even though there are 3 children's hospitals. So even just within this small area, that like limited access can be difficult, right? And then sort of the next place offering OTC would be 200 miles away from our area, right? So I think obviously we did not survey, everyone did not answer the responses. So it would be, you know, very interesting to see who exactly is offering OTC everywhere. But I think that the geography of who's offering it and who has access is still a work in progress. Any thoughts or comments or things other people saw on this that you saw as like for an area of improvement or places that we should be focusing?
This is Mary Zelinsky, and I'd just like to make a comment on the media.
Yeah.
We are actively working behind the scenes to get some manufacturers able to provide this. Other than Sage Origio, we haven't heard back from them how long they're going to continue to provide media. And Mahmoud, correct me if I'm wrong, if you've heard anything recently. It's been a little bit frustrating with non-communication. And we're working with a small company. I'm talking with them tomorrow, actually. And it's going to take some time because, again, none of these medias, even those used in non-US countries, are FDA approved. So it's going to be a little painful for a while, but just know that the effort is there and it's a priority.
Awesome. Thank you. Thank you, Mary, for that update. I was like, I know that it's been being worked on, but so that's really good update on that. Okay. And then the other thing on the study that we thought was interesting and what has came up a lot among pediatric gynecologists who are doing the OTC is the idea of the surgical technique, right? And specifically more recently, conversations about hot versus cold technique. And the survey really does show that the vast majority of us are using a hot technique. So for those of you from a non-surgical background, that means we're using some type of instrumentation with like bipolar or ultrasonic waves to remove the ovary, which international colleagues have came several times and told us that that does cause some loss of follicles. So the cold technique has been suggested. I think some of the pushback on that, and Chelsea, please feel free to jump in here, is that that does make for a longer, more difficult procedure, and, you know, kind of weighing the pros and cons of those. I know it looks like Dr. Gomez-Lobo is not on. I know she has very strong opinions on that and has had some ideas for cold technique. But I did think that was interesting that we're seeing most people using more of a hot technique.
Yeah, and I'm glad that we surveyed about that question because I actually thought that there would be more variation in terms of the amount of tissue taken out based on a discussion I'd had with a pediatric surgeon who she said where she trained, they always took out a segment of the ovary unless the child was very, very young and their ovary tissue was very small. And so I think it was maybe just who was surveyed, but then I think the other aspect to the hot technique that gynecologists tend to worry about, and probably all surgeons, is hemostasis and the fact that these patients have lots of different risk factors for thrombocytopenia or anemia and or both, or these very different reasons why the surgery may have a higher risk of blood loss. And so sort of balancing that risk versus the preservation of as many follicles as possible. I think any standardization of surgical technique is really difficult because there's very few trials and it's difficult to do research specific to techniques. And so then you have certain groups that have published small amounts of data saying we do it this way, but it's not like that was necessarily piloted in a certain way, or just sort of standardizing technique across institutions in surgery in general is challenging. So I think it kind of makes sense that we had these mixed results of people doing it differently. And I think it's an interesting question to consider how moving forward could we better research that or understand it or evolve technique if we, you know, have compelling evidence that a certain technique that is not commonly used is superior. You know, how do we propagate that? So it's interesting.
Any other surgeons on the call performing OTC who have comments or thoughts as far as surgical technique?
Hi, Holly. I have information from Germany, from Ferti Protect. They have the largest series of babies born from OTC, not from the pediatric population, but in general. And they don't use any heat in taking out the ovary or part of ovary. And if they want to do some coagulation, they do this on the remaining part of the ovary. But the piece of the ovary that will be taken out for further freezing should not be exposed to any heat. And they always say this is like boiling eggs for the tissue. So this is a very strong recommendation from them. We heard also from different countries that they also use this hot technique, but I don't think that this is the best way to excise the ovarian tissue.
Yeah, I mean, I do think there's some differences to consider there because I would be interested in what their data on just their pediatric patients looks like, because I think in pediatrics, we are doing a lot more of blood cancers and patients who are coming to the OR, like needing to have platelets to make it to the OR, right? And some of these cases that may not be as common in some adult cancers. And if I'm misstating that, please, anyone feel free to do that. And then also the idea that it seems like that in a lot of the non-US countries in adult patients, they are doing partial ovary, where here for a pediatric patient who is generally always going to be high risk, shown by the data, vast majority of us are taking an entire ovary. And so then you're working with being able to coagulate the main vessel structures to the ovary. So it would be interesting to see the differences based adult versus pediatrics, and then also whole ovary versus partial ovary. I do think it's interesting that that a small proportion of people are taking the tube and the ovary. And that I think would be interesting to look into, because if that doesn't necessarily change the future fertility potential, and by taking the tube and ovary, you then are far enough away from the ovary that you should not be causing any damage to the ovary, right? That is personally, I know at our institution, we kind of, you know, people do that and some people do the oophorectomy. So just, I don't know, any like thoughts on that, Chelsea, or other surgical people?
Yeah, I mean, I guess I was taught to leave the tube in order for like theoretical increased fertility from the remaining ovary. But I definitely think it's an interesting question to consider, because if we're doing this, you know, invasive procedure to preserve the ovary with the assumption that the remaining tissue is unlikely to give them fertility. But I guess I also wonder, in terms of the reimplantation plan, if the majority of patients are going to have the tissue reimplanted in that ovarian fossa, would it be superior for them to have that tube still in place? And I don't know that I have not seen research, looking at that. So that would also be an interesting question in patients who are having an oophorectomy, but not a self-injectomy and do have reimplantation of tissue, if that matters.
So I think obviously not something we're going to answer today, but I do think that is a very interesting question that came up, which I know when we presented our poster at the Oncofertility Consortium was a question that came up that was surprising to a lot of people. And then otherwise, kind of last, just any other thoughts in general, things that surprised you about the survey results or things that you think were like important discussion points that anyone wanted to talk through. Megan, anything from your portion of the talk that you want to highlight?
I don't think so specifically. I mean, I think we know that I think it's unfortunate that there are still programs facing so many barriers at this point when, like the ASRM guidance changed 5 years ago almost. And, I think that there's no question that patients are benefiting from this elsewhere. So, I just think this work is really important. And I think it does give programs who are still plodding along slowly towards having like a really robust OTC offering. It's helpful, at least my institution always wants to see like benchmarking with other programs and things like that. So like this type of data, I do think is important and helpful for programs to have access to. And I know we're looking to, publish a manuscript with it. So that'll be more widely disseminated at that point, even outside of the OFC. Yeah, I mean, I just think these are good questions to hear from other people because these are the types of questions that, our, internal people are asking as well. And I think the more information we can give, that just builds our case. So we certainly welcome everybody's input as we keep going.
Yeah, and I think the most like disheartening part for me about the barriers portion was really that the majority, a high proportion of people without a program, just that they were not able to find institutional like desire for the program.
Yeah,
which
we call it
it's very hard.
Our institution uses a funny word like I don't know what the appetite. There's not an appetite for that. We're like, well, not for you, I guess. But
Yeah.
So yeah, I don't know. It is very unfortunate.
Okay, awesome. Well, and if anyone has anything else to add, we'll give you a couple seconds if anyone just has questions or other input. Okay, perfect. So we will be working on this for a manuscript like Megan had mentioned. So hopefully if this data can be helpful to those of you who are currently practicing or looking at opening up a program, it'll give some data to provide to institutions. All right. And otherwise, I think that we are complete. Mahmoud, anything from your side or announcements or anything you need to do before we finish?
Thank you so much, Holly, Megan, Chelsea, and Amanda. It was a great webinar with great results from your study. I think it reflected the practice regarding the OTC in the US. We are looking forward to compare this to OTC from other different countries also as well. This will be very, very important, but thank you so much. Thank you so much.
All right, great. Thank you, everybody. We'll give you a few minutes back.